Our next panel is on perspectives on compassion and healthcare. Our panelists are Dacher Keltner, who will be speaking about compassionate care in an evolutionary context, Elizabeth Ryder, Reconnecting Healthcare Relationships, Compassion, Values, and Everyday Ethics, Dr. David Spiegel, a colleague of mine at Stanford, who will be speaking on social support and surviving with cancer, and cancer and psychotherapy. So I would like to invite Dacher to begin.
Well, what a privilege it is to be here today, and I'd like to thank Jim for putting this together. I think it's a visionary conference, and I'm just grateful to be around a very big-spirited fellow down at Stanford, Jim, who is doing so much amazing work. Today I'd like to talk about an evolutionary perspective on compassion and compassionate care. I think they go hand in hand and have a lot of relevance to questions that were raised in the earlier session. In a wonderful book by the historian Jonathan Glover, who surveys anecdotes from the world's battlefields in the 20th century, what Glover observes is something that is surprising, counterintuitive, and yet really regular, which is what he calls sympathy breakthroughs, which is when adversaries on the battlefield are face to face and eye to eye and skin to skin, with routine regularity, they break down and collapse into what he calls sympathy breakthroughs. They literally can't pull the trigger, they can't harm, they can't kill, even though their lives are on the line and superiors are demanding that they do so. A famous example was George Orwell, the great writer. He was trained to fight the fascists in Spain. He was in Spain, he had a fascist in his sight, he was about to pull the trigger, and he said, there's just something about that human being that prevents me from pursuing this course of harm. Now, in evolutionary perspective, it's interesting, compassion and kindness and sharing and all the pro-social tendencies that go with this part of human nature have been something of a puzzle or a mystery in how we think about them evolutionarily. Alfred Russel Wallace, the co-discoverer of evolution, took a step back and said there's no way that natural selection would have crafted a compassionate tendency in human beings. Thomas Huxley, who is a popularizer of evolutionary thought during Darwin's day, took a cynical view and said that compassion isn't part of human nature, it's really a cultural construction in which we build it up through norms and values and rituals and the like, which no doubt is true, but he made the case that it really isn't part of our DNA, of our evolutionary fiber. Now, it's interesting, Charles Darwin, coming out of taking care of his young daughter Annie, who had passed away at the age of 12, and he was really the one who nursed her to her early death, arrived at a much different view of human beings that often surprises people as they encountered this. And this is from The Descent of Man from 1871. And it really is the spirit of CCARE and this movement, which is Darwin argued that sympathy will have been increased through natural selection for those communities which included the greatest number of sympathetic members will flourish the best and will raise the greatest number of offspring. Very simple evolutionary perspective on why we have evolved to care. There are simple reasons why this is true. It's an evolutionary prerogative. So one of them has to do with these photos right here. These are our two primate relatives, the bonobo on the left, that matrilineal hypersexual species that most humans envy, and then the chimpanzee on the right. And needless to say, what evolutionists have started to make the case for is that our primate relatives are fairly independent early in development because of various processes that happen in our physical evolution. Human babies are very dependent, requiring 7 to 45 years to reach the age of independence. Now, that simple fact, and it's just a basic shift in our evolution, rearranged our nervous systems, as Sue Carter and Stephen Porges have long been arguing, whom you'll hear for, and it rearranged our social structures, as anthropologists have made the case for. So I'm going to present data that we've really been gathering in our Berkeley lab. Various speakers here have been part of this, that really make the case for 3 different reasons why we can start to confidently believe that evolution has crafted compassion into our nervous system. The first is the analysis of signaling behavior. And it's interesting how many observations in the first session talked about listening and communicating and using a tone of voice with patients as part of care. What Darwin inspired in a different book in 1872 is we can look to the signaling of human beings in all of its manifold variety, trace it back in phylogenetic comparison, and start to make a case for where particular emotions like compassion emerged in human evolution. I started my studies of the signal of compassion by looking at the human face. I give you a photo on the bottom right that's an example of this. More recently, we've done some emoticon work at Facebook, how people convey compassion. That wasn't too successful because the real language of compassion is in an anatomical wonder, which is called the human voice. This is a drawing of of our vocal anatomy. As you know, air particles move up through your vocal chamber, hit your vocal cords, vibrate, produce sounds that are perceived by big parts of your brain to communicate all manner of things psychologically. And my lab got interested in, can we capture brief sounds that convey compassion, which are called vocal bursts? No words in them, but little sounds that signal that I care for you. How important in the therapeutic context. I'm going to count to 3, and I want you to produce a vocal burst of compassion. No words, just a sound. 1, 2, 3. Well done. I think Jim's been working on this with you guys earlier in the morning. So,
It took an hour.
I recently did that at Goldman Sachs. I kid you not. 1, 2, 3. And they're like, I don't know what this guy's talking about. So I won't comment. What we do in our lab is we present those sounds without any context to observers around the world. We have them judge what the emotion is. These are just data showing you compassion coming in at 50%. 7 to 8% is what chance guessing would produce. Compassion is well above chance guessing. We can pick it up in the human voice. We've now got data coming in from the Himba in Namibia and in remote Bhutan showing the sounds you produce here are quickly perceived by people who have never had contact with the West as signs of compassion. Primates have 6 or 7 different vocal bursts that resemble human vocalizations. One of them is called the coo or gurn, which they emit around baby primates that sounds a lot like compassion, tracing it back in evolutionary history. Second point, is compassion viral? Indeed, there's a lot of tremendous new data that healthcare experts should really be drawing upon, showing how viral and contagious compassion is. I've given you some examples here. What I'd really direct your attention to is the work of James Fowler and Nicholas Christakis, who've really done the hard social network analysis showing compassion in one part of an organization can spread virally and unconsciously to other parts of the organization over time through very interesting processes we can talk about at the break. My lab got interested in something we've been talking about a lot today, human touch. It's one of the most sophisticated ways in which we communicate with each other. We have an amazing hand that is incredibly dexterous, hundreds of millions of cells in your skin on the right, which include, by the way, your immune system. There's tremendous science of people like Michael Meany and Darlene Francis at UC Berkeley showing tactile contact in mammals actually calms the stress response, stimulates immune system response, and the like. I was interested in, with our lab, is touch really this viral language of compassion? So we did this crazy study at UC Berkeley, where we were allowed to do these crazy, unethical studies, in which one person came to the lab, stuck their arm through a barrier, another person came to that same lab, was given a list of emotions. They reached out and touched the forearm and tried to communicate different emotions. The person who was touched just guessed what happened. They tried to guess which emotions occurred. And what you can see in the blue bars is chance guessing in this study of discerning what emotion is communicated with touch is 8%. And people are 6 or 7 times better than chance at picking up compassion, which is with a subtle half-second touch to the forearm. There were a couple of gender differences in this study. When women try to communicate anger to male arms, the male arm had no idea what was going on. And regrettably, when men try to communicate compassion to the female arm, the female didn't even think it was the human species and got nothing right. That's neither here. By the way, did a study of NBA teams. This would be great to model in hospitals. The more NBA teams touch at the start of the season, 1 minute and 48 seconds overall in the game, the better they perform later in the year, and they get more victories. The final part of proof is inspired by Steve Porges and Sue Carter, and you'll hear more about this later. But what I can tell you is there is a neurophysiology of compassion. As was mentioned earlier in the panel, it's built into our DNA. So when we present images of suffering in our lab, Steve Porges has been making the case for a long time. It activates a part of your peripheral nervous system called the vagus nerve. It does in about 6 or 8 studies in our lab, soon to be published. It activates a very old part of the brain, the perioccipital gray, which is communicating with oxytocin receptors, as Sue Carter has been making the case for a long time. We have evolved. These are old parts of the mammalian nervous system. It is an instinct, as Darwin proposed. So at the Greater Good Science Center, we're doing a lot of different things about compassionate health, such as touch, different contemplation practices like Jim is promoting at CCARE of compassion training. And one I'll draw your attention to, which we're really excited about, is the power of green spaces. The mind has evolved, and all these systems are activated, we're finding, by simply standing around beautiful trees, which is very cheap healthcare indeed. Thank you very much.
So I want to start out by thanking Dr. Doty and CCARE at Stanford. And I want to thank Dignity Health as well for their generous support of these conferences this week. It's been wonderful. So I'm going to start out, basically just quick run through. We're going to talk about relational competency, and the difference between patient-centered and relationship-centered care, interpersonal and communication skills, talk about the ethics of everyday practice, human values, the International Charter for Human Values in Healthcare, and the Charter in Compassion, all in 10 minutes. So what's happening in healthcare today? Tell me, doctor, how much time do I have left? 10. 10 what? 9. I'm a pediatrician and also a former child and family therapist where we got at least 50 minutes, and then as a pediatrician we get 10. And by the time the snowsuit is off in Boston or the diaper's off and the child is weighed, you have 6 or 7 minutes to do that. So there's a real issue going on, I think, with efficiency, productivity models, and I was so inspired by the speakers this morning about how can we bring this humanism, bring these relationships, this compassion and kindness back into our relationships in healthcare. In the 1980s, residents spent 20% of their time with patients. In 2012, they spent 12% of their time with patients. And all of your healthcare professionals are spending more time with the computer than they are with you. So it's a real issue. And I just want to start out just to ask a couple questions. How many of you have been patients? This includes your flu shots or various things like that. How many of you are clinicians or educators, researchers? So working with patients. And how many of you are human beings? Just checking. So here's the bottom line. How do we create compassionate healthcare? It's all about relationships. There's many studies that support this. And then I'm going to talk a little bit about relational competency. We're doing that at the Institute for Professionalism and Ethical Practice, where I am at Boston Children's Hospital and Harvard. The relational competency is the ability to form deeper relationships with patients and families that goes beyond developing a set of communication behaviors or skills. This is beyond the checklist, essentially. I think authenticity and being real is more important, perhaps, than the mastery of skills and techniques. Now, you do need your skills and techniques for your neurosurgeon, and you need all those, the throat culture, whatever it is, but you really need that relationship. I think that's what the soul of medicine is to me, and that's what's healing. So the question becomes, rather than teaching to a checklist, how do we enhance being present? Are you all present? Maybe. The ability to develop a sustainable relationship that allows for repair when mistakes are made. So we really want to train all of our healthcare clinicians in all professions a way of being. It's not just skills and tasks. They need those skills and tasks, but it's also a way of being. So how many of you are familiar with patient-centered care? Excellent. How many of you are familiar with relationship-centered care? Oh, a little more, yeah. So patient-centered care emphasizes a patient's illness experience. We look at the patient as unique, not just, the factory, not just, the kidney in room X. Focuses on the patient's needs, tailors the approach to the patient. But relationship-centered care takes that further to address patient-centered care, but also the relationship between the clinician and the patient, and what the clinician brings as well, because that's the relationship. So it captures the importance of interaction among people as the foundation of any therapeutic or healing activity. So relationship-centered care focuses on how patients and physicians and clinicians interact with each other. It's a medium of care. It's therapeutic. Our relationships are therapeutic. There's a partnership between patient and clinician. Also talks about being present for yourself, being aware of your feelings. All of us have certain patients, I'm a pediatrician, come in and they might push our hot buttons. If we can be aware of that, and so to say to ourselves, well, it really bothers me when I have X kind of patient. For me, it's Munchausen by proxy, which is parents hurting their kids. Then we can go in. We can say, okay, this bothers me. I'm aware of this. But then you can go in and be compassionate and kind and relate and do the best you can. So relationship-centered care is about interactions within the clinician, between the clinician and patient. It also has to do with paying attention to our own behavior. I do some work with dying children, which is very painful, and they are not going to remember the respirator, the drip, the techniques, the science. They're going to remember what was said to them during that process. So what we say is incredibly important. So communication and interpersonal skills, these are also different. We teach a lot of communication skills in medical schools, and these are tasks or behaviors. You sit down, you have eye contact, you turn off your beeper, that sort of thing. But that will not itself, those are important, manners perhaps, those cannot create or sustain a therapeutic relationship in and of themselves. So we need to move beyond to interpersonal skills. Those are relational and process-oriented. This also applies to interprofessional care, colleagues, team in the teamwork. So just to give you a brief taste, what are interpersonal skills? You're aware of that relationship and how important it is and your effect on others. It's authentic, it's honest, it's presence. You want its capacity for compassion, kindness, and a caring intent to relieve suffering, and relational versatility. How many of you know what differential use of self is? Yeah, I was trained initially as a therapist, so we talked about that. And that's the ability to adjust your interaction, the way you interact with people, and your interpersonal skills based on the needs of who you're interacting with, the patient or the family. So another concept about relational competency is the ethics of everyday practice. We live in the same moral universe about all of us, patients, clinicians, being fair, respecting others, what's the right thing to do in any given situation. This also, again, applies to interprofessional care. So I want to read you this quote, which I particularly like. This is done by Edmund Pellegrino, which was the founder, I guess, of bioethics. He died at age 93 in 2013, and I wish I'd found out about him before that. But he has some wonderful writings. He says medicine, and this is also healthcare, medicine is a moral enterprise. And if you take away the ethical and moral dimensions, you end up with a technique. The reason it's a profession is that it's dedicated to something other than its own self-interests. So it's much more than throughput, productivity, the factory work of being technicians. It really has a whole lot of ethical and moral dimensions. So human values are the foundation of our work. And how many of you, particularly those who are clinicians, that are practitioners, how many of you were explicitly taught values in your training? Like really addressed, like we assume professionalism, all the doctors, are compassionate, have integrity, but how many of you were really taught it was in the curriculum, you discussed values, you may have written about them, explored them? How many? Not too many, maybe 6 or 7. And this is what I get. Some audiences, there's no one. So we need to start explicitly teaching this because values are the anchor. So I'm just going to tell you very briefly about the International Charter for Human Values in Healthcare. It came out of the first International Roundtable on Healthcare Communication in early 2011, and we just sort of it just sort of bubbled up synergistically. And basically, it's an effort to identify core values that are necessary for practicing compassionate, ethical, and safe healthcare around the world. We asked multiple groups, hundreds of people, hundreds of healthcare professionals, caregivers, patients around the world, 2 questions. Drawing on your professional experiences and your experiences as a patient, what are the core human values that should be in every healthcare interaction? So people would list those, and then we asked them to list their top 4. We did, I'm not going to get into the research here, but we did utilize many qualitative research methods to see where this would all sort out. We came up with 5 main categories of values: compassion, respect for persons, commitment to integrity and ethical practice, commitment to excellence, and justice in healthcare. And the thing that absolutely amazed me, and I guess it really shouldn't have, is that people around the world, whether you're in Asia, if you're in Hong Kong, China, Malaysia, if you're in Australia, the Netherlands, Europe, here, they have the same categories of values. Now they might say, well, this one's a little higher than this, or this one's a little more important, but it's the same 5 groups. And that's what, but we're all human beings. And you all said you were human beings, so we're good. So, and each of those values, each of the categories has sub-values. I'm just showing you the one for compassion. You can sort of read there: caring, empathy, self-awareness, flexibility, and adaptation in relationships. Altruism, curiosity is really important. Kindness. This is what's sorted out just from worldwide things. And there's your Wordle, or your word cloud of all of those. So very quickly, the bottom line of what we're doing internationally, we invite all of you to be partners. We would love it. We want to identify and promote core values, and that relationships and skilled communication is required to demonstrate those values. You might feel a lot of compassion for a patient and you're with a patient, but if they don't sense that you have that compassion, if they might think you're cold or distracted or something else, so we need to think about how do we demonstrate them, verbally, non-verbally, to be just aware of them, to pay attention to them. Now, I know not many of you were taught them, but it's in our genetics, I think. And so we need to explicitly teach them. Very quickly, the International Charter for Human Values in Healthcare is an initiative of IRCH. We call it IRCH, the International Research Center for Communication in Healthcare. We have 80 members in 15 countries. And we are also working very closely with the Charter for Compassion. How many of you are aware of the Charter for Compassion? There you go. Excellent. So, IRCH is now the Asia-Pacific healthcare hub of the Charter for Compassion, and if those of you are around on Saturday, you'll hear more. So we want to invite you to become involved. Everyone's invited. The Charter for Compassion, you can see the website there and find me, and I'm here all weekend. I can give you those websites. Also, the International Charter for Human Values in Healthcare, of which compassion is probably the most important of those 5 categories of values. You can check out that website. So I want to leave you with a Japanese proverb. None of us is smart as all of us. So all working together, all around the world, all here at Stanford, all everywhere, on these issues of compassion, kindness, and medicine, we can do a whole lot. So there's some references, find me, and I can actually have some of them I could provide, and I want to thank you.
Thank you. Our next speaker is Dr. David Spiegel. We've been talking about social connection, and he is going to speak with us about social support and surviving cancer. Thank you, David.
Thank you. Well, it's a privilege to be surrounded by so many people who have a common passion for compassion. What I hope to show you is evidence that compassion, not just between healthcare professionals and patients, has therapeutic potential, but that compassion among patients and between patients and their families has a tremendous effect on healthcare. So being compassionate is not just a nice thing to do. it's good medicine. I'll talk about the relationship between survival and social support, some psychotherapeutic interventions we have studied, treatment outcome, effects on survival, and some conclusions. When I started running support groups for breast cancer patients, I was warned that I would demoralize patients, that women with advanced cancer would watch one another die, we would demoralize them. So I had the opportunity to ask His Holiness the Dalai Lama why it might be that having compassion for someone else, taking on someone else's misery, despite your own, might actually be helpful rather than hurtful. And he said, in the case of experiencing our own suffering, there's an element of involuntariness, in fact, a lack of freedom. And when you empathize with someone else's suffering, when you embrace others' suffering, there's a voluntary dimension. In fact, that kind of voluntary action comes on the basis of a choice and also of a freedom. Because of this, you have a freedom that also the experience may be painful, but that is qualitatively different from experiencing your own pain. So the idea of combining experiencing pain and suffering with the choice to do so helps people transform their own suffering. We are social creatures. Social isolation is as bad for your health as smoking or having high serum cholesterol levels. This is a review published in Science showing in 5 large studies that being isolated doubles your risk of all-cause mortality, independent of other risk factors. And this paper was just published in the Journal of Clinical Oncology a year ago. It's big data, 734,000 patients, 5 years of cancer patients in the CCARE registry. And what it showed was that being married substantially increased your odds of survival. It might interest you to know that the effect was stronger for men than it was for women, but even women obtained some survival advantage from being married. And this effect was not simply due to being brought to treatment sooner, which was the case. It was not simply due to getting better treatment, which was the case. When you controlled for that, marital status had a stronger effect on survival than many of the chemotherapies we use in cancer treatment. And that statement was in the abstract of this paper. Cancer patients live every day with terrible stress. They can't forget it. It's not one big stress, it's a series of stressors. One of my patients had been an engineer. She changed her career when her disease advanced and became an artist. And she brought this dressmaker's maquette into one of our groups to show us what her body felt like from being treated for cancer. The way people react to cancer has an effect on their survival. This is a study in which we looked at the course of depression among women with advanced breast cancer and found that it predicted survival up to 15 years later, independent of all other risk factors. So mood alone, depression can predict poorer survival outcome with breast cancer. Well, what do we do about depression? One way, this is the New Jersey Turnpike, actually, shortly after Governor Christie shut down the Lincoln Tunnel, I think. We get patients together in groups to express things that they have trouble expressing elsewhere. Most of us don't know, and those who do won't tell, so we build you a reason, a barrier to shut out any probing of our scars, self-inflicted or not. If you'll love us a little and let us weep when we must, we may find out who we are. The kind of intervention that we have created, we call supportive expressive group therapy. It involves helping patients give as well as receive help from one another. Express rather than suppress emotion, no happy faces, no prison of positive thinking. Detoxify fears of dying and death, reorder life priorities, strengthen their relationships with families, improve communication with doctors, and learn how to manage symptoms. We try to convert anxiety into fear and depression into sadness. If you can focus what the misery is about, you can begin to think what you can do about it. Thomas Jefferson said, when angry, count 10 before you speak. If very angry, count 100. Mark Twain said, when angry, count to 4. When very angry, swear. We're on the Mark Twain side of that one. Shakespeare said it best, give sorrow words, the grief that does not speak, whispers the oft-wrought heart and bids it break. And we were able to show in a randomized clinical trial that we could reduce the suppression of emotion in these breast cancer patients compared to patients in the control condition. And they felt more efficacious in managing their affect when they were less suppressive of their anger, fear, and sadness. We help people face dying and death. There's nothing we can do about being dead, but there's a lot we can do about how we die. And they learn to find something to do about the thing, even the thing that frightened them the most. One patient circulated these cards when another died, wrote, "Dear Eva, whenever the wind is from the sea salty and strong, you are here. Remembering your zest for hilltops and the sturdy surf of your laughter gentles my grief at your going and tempers the thought of my own." So they drew strength from one another's death. Another woman said that being in the group was like looking into the Grand Canyon when you're afraid of heights. You know, it would be horrible if you fell, but you feel better about yourself because you're able to look. I can't say I feel serene, but I can look at it. So empathizing, even in the extreme situations of dying and death, strengthened our patients. We were able to show in this randomized trial that we reduced their anxiety and depression compared to patients, the green line in the control condition, despite facing the worst kind of existential issues, and we replicated that finding in another study 15 years later. This is a meta-analysis, a Cochrane database review that showed that even in the face of advanced cancer, we can significantly reduce depression in women and men with cancer. Why doesn't medicine do more of this? Patients often feel punished by their doctors. Here's why. I'm sorry, Mr. McConnell, your insurance plan only provides for empathetic nodding and a saddened downward glance. There's a $200 copay for any additional words of compassion, not to exceed 40 words or 3 expressions of sympathy or condolence. All I can say is I wish this were funny. Unfortunately, it isn't. And if there's one statistic I'd like you to go away with, it's that the bloated, inefficient government healthcare system, Medicare, which cares for the sickest patients, their overhead rate for managing all that care is 2.7%. The sleek, efficient, competitive private insurance industry, their overhead rate for care is 27%. So as Dr. Doty said at the beginning, we have one of the least efficient healthcare systems in the world, largely because we spend more on insurance companies than we do on doctors, and that's wrong. So finally, what is the effect of this kind of shared compassion among patients and with families on survival? I was so fed up with the wish away your cancer idea that if you keep up a positive attitude, you'll get over cancer, that I wanted to look at the survival outcome of these randomized clinical trials we did. And to my surprise, women randomized to supportive expressive group therapy lived 18 months longer than control patients, independent of all the other risk factors. We published this in The Lancet in 1989. It got a fair amount of attention. We tried to replicate 15 years later. We then found not an overall effect, but an interaction such that the women with the worst prognosis cancers, ER negative, triple negative cancers, survived longer if they were in our groups. And we think one reason may be that there was a tremendous improvement in hormonal treatments for breast cancer in the interim. So women with ER positive cancer were getting the benefit of much better hormonal treatment. The ER negative women were not. Barbara Anderson at The Ohio State University found a similar effect, randomizing women with early-stage breast cancer to support groups or control condition. The support group patients lived longer. This is a fabulous study published in the New England Journal a few years ago by Temmel and colleagues at Mass General. Patients dying of non-small cell lung cancer were randomized to palliative care with support for their depression and pain versus standard care. They reduced their depression and anxiety substantially, but independent of that, they lived 2.5 months longer on average. So providing care even at the very end of life not only improves quality of life, but it improves quantity of life. There are now 15 randomized trials examining the question of whether psychotherapy, applied compassion, has a positive effect on survival. 8 of them show that it does. 7 show no difference. And I'm happy to say that not a single trial shows that psychotherapy kills patients. So the studies aren't uniform, but they provide strong evidence that applied compassion not only improves quality of life, but quantity of life. So patients will thrive when they have a web of support. When we address their depression and sadness, when we handle stress better, and we have evidence that stress-related disruption of the cortisol system throughout the day actually predicts shorter survival with breast cancer. When we help them sleep better sleep efficiency also predicts survival. So a lot of these basic factors in living, emotional support, sleep, exercise, and other things can actually make an effect not just in how well people live, but in how long they live. Emotions can connect us to one another. Social support is crucial for health. Feeling better may lead to healing better. It isn't just mind over matter, but mind matters. So we try to transform patients from feeling terribly damaged by the disease and its treatment to transcending it. When you look at the Winged Victory of Samothrace in the Louvre, you don't say, my, there's a woman who's missing her head and her arms. You see it as an image of transcendence, and that's what people, even with advanced disease, can learn to do. I want to acknowledge and thank our research support, including the National Cancer Institute, the National Center for Complementary Alternative Medicine, the National Institute of Mental Health, the Breast Cancer Research Program in California, the Dana and the MacArthur Foundations as well. Shakespeare gets the last word. When we our betters see bearing our woes, we scarcely think our miseries our foes. The mind much sufferance doth o'erskip, when grief hath mates and bearing fellowship. Thank you.
Our next speaker is Dr. Paul Gilbert, who some of you have heard previously. He's going to talk about the effects of compassion in the psychotherapy environment. It's interesting, what we're repeatedly seeing here is the impact of compassion to activate the vagal system and have all the effects that we've already seen through previous talks, including Dacher's, about its impact on health, well-being, and ultimately longevity.
Okay, well, once again, thank you so much for CCARE inviting me and all the wonderful work that Dr. Doty does. So in being a psychotherapist, it means you have to touch the minds of others, and in doing so, you will encounter deep terror, deep fear, deep depression, the desire to kill oneself because life seems so pointless. This means that we need to be thinking about compassion in terms of what it actually involves, which is this sensitivity to suffering in self and others with this deep commitment to try to alleviate, to prevent it. And that means that we have two different types of psychologies here. The first psychology is the psychology of engaging, the desire to discover, to be with, to stay with, to hold with, and that involves courage, because sometimes the pain that we hear about is very unpleasant indeed, and also there is the commitment to work to alleviate suffering. Now this has to be part of the patient's journey as well, because the patient is going to have to confront things in themselves that they've often been trying to avoid, be it traumatic memories, be it anxiety, be it paranoia, whatever. And that means that we need to understand the roots of these things. Compassion then is also about helping us to understand the causes of suffering. That means we need to see into what is behind it. And a lot of the reasons that we are vulnerable to the suffering that we have, both physical and mental, is because of the way our brains have evolved. Our brains and bodies have evolved. So our brains are designed for you. They weren't designed by you. They're designed by your genes. You have a whole lot of stuff goes on in them that's there because of evolution. We are all born, we grow, we die, we decay. No one in this room will avoid that. Some of us will sadly die slowly. Some of us will die in pain. That is the reality. And once we understand the reality, then of course we need to all share together. We are all in the same boat, as the Dalai Lama says. The nature of impermanence is that nothing stays the same. We also know that we are socially shaped beings. If I had been kidnapped as a 3-day-old baby and brought up in a violent drug gang, this version of Paul Gilbert wouldn't exist. A totally different version would exist. Possibly a very violent, very unpleasant version. Even as we saw from Stephen Cole's yesterday, my gene expressions would be different. So I didn't choose the brain that I have, and I didn't choose the social conditioning that created me and made my phenotypes. So the point is, a lot of what goes on in my mind, in my head, is not my fault. And we spend a lot of time helping patients understand that, to help them to depersonalize from all of the struggles and the traumas that are going on in their mind. And one of the reasons that we have so much trouble with our brains is because of the way in which they've evolved. Over about 500 to 700 million years, there's been a whole range of motivation and emotional systems that are evolving, but it's only been in the last 2 million years that we've developed the capacity for what we call human intelligence. And this is fantastic in many ways. It's why we're here, it's why we have medicine, but it also causes us a serious set of problems. And Dr. Doty and I have been discussing the fact that the human brain is a serious problem for humanity that we really need to try and understand. And one of the reasons for that is because our cognitive competencies can stimulate and stir up quite a lot of bad stuff. So imagine, for example, a zebra trying to escape a lion. What happens is that the zebra escapes, and then their level of arousal will go down, but we have this fantastic new brain, so what will happen for us is we'll start thinking and dwelling. Can you imagine what would have happened if I'd been caught? Oh my God, been eaten alive. Then we become self-critical. Why did I go there? And then we worry about tomorrow. What about 2 lions tomorrow? Oh my God. Now, of course, one of the things is how we deal with all these loops in the mind that hold us is by mindfulness, that's one aspect, and also by developing compassion, because compassion is a motivational state. Motivational states are absolutely crucial for how our minds are organized. Okay? So if you're motivated for competitiveness, your mind will be organized in a very different way than if it's organized for compassion, because we saw what the definition of compassion was. This means that compassion will organize your attention and your thinking and your behavior in a very different way to that. So once we understand motivational systems as organizing systems, then it's very clear that we need to be training those systems. We also know that emotions serve the needs or the aims of motives. And there are three basic functional emotional systems, one of which, of course, is the threat system. And this system is designed to help you take defensive action and prevent harm. The other is the drive system, which helps you get out into the world and do things and achieve resources. But the other is a soothing system, which, again, has been mentioned, Steve Porges will be talking later about, is involved with the parasympathetic system. It's a calming system. It's a system which is absolutely crucial for the balancing of the mind. So what we know is that there is a capacity which is linked to oxytocin, parasympathetic systems that helps us to calm threat. This is often achieved through the loving kindness of one's parents early on in life, but as we grow, we learn how to be soothing and supportive of ourselves. Those who are very self-critical can't use this system. Now, we wanted to find out if we could look at this, find measures of this, so we did a little study where we looked at people's characteristic emotions. And so they were asked, how characteristic is it for you to feel energetic, excited, relaxed, and safe, on the assumption that there would be two types of positive emotion, one that's stimulating and activating, and then one that's calming and gives feelings of contentment and peacefulness. What we actually found was something quite different, and this has been replicated in a Portuguese sample. In fact, what we thought was the calming emotion split into two. One was relaxation, but the other was safe, content, secure, and warm. And it turned out that when we looked at the correlations, the lower ones, the ones in yellow are depressed patients, the white ones are the students. We found that it's the safe experience of safeness is the most powerful positive affects that are linked to the reductions of anxiety and depression. So being energetic, being able to do things, that's great. But if you have the ability characteristic ability of feeling content, warm, and secure, then this really does seem to be quite protective. When we talk to our patients, what we help them understand is that the stimuluses come inside the head. So if you see a fantastic meal, and you're very hungry, this will stimulate your stomach acids. But of course, if it's late at night and you have to imagine one, you can do the same thing. If you see something very sexy on the television, this could stimulate your pituitary, it gives you sexual arousal, but you can lay in bed without anybody there and do the same thing. You can stimulate your own physiological systems with what's going on in your head. In fact, one of my patients said, I know what you mean, Dr. Gilbert. He said, I prefer a fantasy because you meet a better class of person. Now, the point is, if you're somebody who's being very critical and bullying yourself, what you're doing is you're stimulating your threat system day in, day out. You're not able to generate what you actually need, which is the capacity for compassionate soothing. You need to get the parasympathetic system going. You need to get that state going. And again, Steve Porges is going to talk to you about this later. So the point is, we just use a very simple system, same system, that what you create in your head can stimulate your physiological systems. And so this is what we do then. We're highly focused on developing mindfulness through the breath to stabilize and ground. Because if you're going to engage in pain, if you're going to engage in suffering, if you're going to move forward into dealing with your trauma or whatever it is that's causing you to be painful, then you have to have the capacities to do that. If you're going to climb Mount Everest, it's a good idea to get fit first. And so a lot of what we do is actually creating the conditions for us to do the work. So we use both mindfulness to stabilize the body, to give it a sense of slowing, try to activate that parasympathetic system that Steve will talk about, but also then to create compassionate motivation. Because what we're wanting to do is to cultivate and build motivational systems, because it's motivational systems which reorganize your mind. And when people are orientated towards being compassionate to themselves and others, things change for them. Another way of thinking about this is that compassion provides you what we call the inner secure base or inner safe haven. So this is how we do it then. Important for compassion-focused therapy, we help the patient understand that a lot of what's going on in their head is not their fault. It's because of the way the human brain is. There is no fantasy that you can have, probably no negative emotion that some other human being, at least at some point in history, hasn't had. We are created by our genes and our environment. And if we personalize and think, no, 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 this is about me being a bad person, this is about me being an unlovable person, then we will get trapped in the threat system. So it's very important then that we help people understand this evolutionary nature of mind, and then to begin to balance the emotions, primarily, but not only, by stimulating the soothing system, because it's often the green soothing system that patients don't have access to. We also have to develop compassionate motives. We do this through breathing. Again, Steve will be talking about this. Posture, voice tones. What you say and the way you say it is very important. Okay, so even if you're doing cognitive restructuring, if you're saying it in a hostile way, this isn't going to help you. So even if I say something like, everybody wants to be happy, if I say it, everybody wants to be happy? Or I could say, everybody wants to be happy. Or I could say it's sexy. Everybody wants to be happy, right? The voice tone is crucial to how something emotionally impacts. So we do a lot of training in people's voice tones. We do training in facial expressions, we do training in body posture, we do training in compassionate behavior, we do training in what we call safe place, which we distinguish from safety. Safeness is the ability for freedom and joyfulness, so we do training on that. We do a lot of training with ideal image. And we do a lot of training with compassionate self, where we use method acting techniques. So just very quickly to provide you something that an early study that we did with some of our patients. It was a day hospital. These are very patients who've been there quite a long time. They've often got very difficult backgrounds. And so I came in one day and said, look, I've got this therapy. It's compassion-focused therapy. Would you have a go? And they said, oh, not another one of your bloody therapies, Gilbert. So I said, no, this one's going to work. Yeah, I promise you. So anyway, so we got a number of them to sign up. And what we found was that we did find a nice drop in self-criticism, which was good because that's what we were trying to do, and an increase in self-compassion. We found changes in anxiety and depression. Don't worry about that one. And I'm going to leave you now with some reflections of what they said about the therapy. I would just like to tell you here today what compassionate mind training means to me. It seems to awaken a part of my brain that I was not aware existed. So we often hear that. Oh, I don't know what's happened to that one. Okay. Having compassion for myself means that I feel so much more at peace with myself. And that's the point. See, the soothing system is about creating a sense of peacefulness. It's not about going out and achieving and doing things. It's creating this sense of inner peacefulness. And to realize it's a normal way to have compassion for myself. It's not abnormal. It's a very healthy way of thinking. I felt like I was training my mind to switch to this mode when I started to feel bad about myself, or life situations were starting to get on top of me. So I'm going to stop there because I'm out of time, but there are other quotes like that. And what a lot of our patients say is that they learn how to take the breath, they learn how to focus on the body, they learn how to create the voice, they learn how to connect to their true motivation. True motivation is to develop courage to face the issues that I have to face, and when they do that, we see change. Thank you so much.
So it's really wonderful to see how this builds on Dacher's comments about our evolutionary construct and all these mechanisms of responding to voice, to touch, to facial expression, and how ultimately they impact the clinical environment. What I'd like to do actually is see if there is a question from the audience, and she already knew I was going to do that, for our panelists, and we're going to do 2 questions, and then we're going to move on. Yes?
My question is for Dr. Keltner. Thank you very much for your presentation and for your very beautiful and inspiring research. You have shown us, and your lab have shown us, that compassion is a root evolutionary emotion, and that it has some evolutionary functions as taking care of vulnerable offsprings, and is also a wanted trait in mate selection, and also creates cooperative relationship with no kins. And my question is, which are your thoughts on compassion for the self? Because this applies for compassion for others, but which are your thoughts for self-compassion, given that the same 3 evolutionary purposes do not apply? Thank you.
Yeah, that's a great question. Thank you for the summary. So you've summarized all the arguments we've made from an evolutionary perspective about why compassion for others and why we have this big parts of our brain responding to suffering and the systems that help us aid others. And you've pointed out, I think, an interesting puzzle, and I'd actually like to hear Paul Gilbert on this as well, that we're learning from Paul's work and Kristen Neff and others that there's this enormous power of kind of taking the apparatus of compassion and directing it at the self, and it calms anxiety and depression. I mean, from a strict evolutionary perspective, I would probably argue that is sort of a later development in kind of the architecture of compassion. But I'd love to hear Paul's thoughts, because I know he's been thinking about this.
Paul, could we hear it, though, with the sexy voice?
Okay, here we go. Okay, so here's the deal, right? The new brain has brought in the stimulus inside the head. That's the first thing, right? So it means that what you create in your head will stimulate these old physiological systems. Now, Dacher has done a fantastic job in showing us how and why they got to be there. Okay, so we know that it's linked to kin protection, kin caring, and so on, a few other things as well. But once you've got them in your head, you can now stimulate them in lots of different ways. And one of the things that happened for human evolution is we developed what we call a self-monitoring system. So we can monitor ourselves. So you'll never see a chimpanzee sitting under a tree going, "Oh my God, my pulse is so fast. What's happening?" You'll never see them worry about putting on weight or anything. Humans can do this, right? So the way in which humans are able to think about themselves as objects and so forth is very important. So if you're thinking about yourself or experiencing yourself in a very negative way, you're stimulating these threat-based systems, your amygdala and so forth. In fact, we've done fMRI studies where we've asked people to be self-critical and self-soothing, and we find that they stimulate very different brain areas. So the self-monitoring system gets hooked up with monitoring the self in a negative way. So it's simply the other side of the coin is that if you teach people how to use the self-monitoring system, but to focus in on the generated compassionate voice and so on, then you'll be stimulating those systems, which Steve August and Sue Carter and Dacher all have identified and showed that those actually create major physiological changes. Whether or not self-compassion has any long-term distal evolutionary genetic change, I don't know if one could answer that. We will have to see, in the same way that we don't really know if this 2 million-year-old brain is going to do us good or bad in the long run. We don't know. But at the moment, it's just to see that it's the way in which we stimulate these systems with the self-monitoring system.
I think, actually, unfortunately, we don't have time for another question. I apologize. We're going to go right to our next session. Thank you, panelists. I appreciate it. Thank you so much. Thank you. Thank you, Dave.